¿Dónde he estado? Ay, Dios mío, odio el autocorrector.
All right, so today we're going to talk about the management of the patient with acute stroke. This is another, I think, great topic. There's some recommended readings for you, mainly DePero and a guideline and a couple other primary lit. Please familiarize yourself with the learning objectives. The case application and any exam questions will be taken from these. I'd like to start off with some definitions first to get everyone on the same page. Cerebral vascular disease is a disorder affecting the central nervous system vasculature, resulting in neurologic dysfunction. It occurs due to ischemia or hemorrhage. So we're going to talk about two different types of stroke today: ischemia, or lack of blood flow to the brain, or hemorrhage, or a rupture of a vessel causing hemorrhage in the brain. So stroke is a neurological deficit of cerebral vascular that persists for more than 24 hours or leads to death. So the injury persists for greater than 24 hours. This is important because a transient ischemic attack, also called a mini stroke, this can be a neurologic dysfunction caused by ischemia without acute infarction that resolves within 24 hours. So the main difference between an ischemic stroke and a TIA, or transient ischemic attack, is the timing. So less than 24 hours for a TIA or greater than 24 hours for a stroke. The TIA, importantly, does not cause permanent damage, most likely due to the less amount of time of the insult. So, like I alluded to before, stroke can be divided into hemorrhagic and ischemic. Ischemic can be further divided into atherosclerotic or embolic, whereas hemorrhagic, there's three main types: subarachnoid hemorrhage, intracranial hemorrhage, and subdural hematoma. As far as etiology, ischemic strokes are certainly the most common as opposed to hemorrhagic. So 87% of the patients presenting with a stroke will likely have ischemic stroke. Again, this is due to thrombotic or embolic occlusion. You can see on the diagram, the cartoon on the left in blue, we have the two causes. Thrombotic, a blood clot forms locally in the brain and blocking the blood flow. So this would be the clot right here, and it blocks the blood flow distal and then causing a neurological insult. Whereas embolic would be a blood clot formed in the body, travels through the bloodstream. So it could be originating in the heart, travels through the bloodstream up into the brain, and then it blocks the artery. So those are two major forms of ischemic stroke. So either it originates in the brain or out of the brain.
So if a patient is having like a really bad hypertensive crisis, is he like is he in a greater risk for a hemorrhagic stroke?
Yes, but hypertension, we're going to get to risk factors. Hypertension could be a risk factor for either one, but certainly for hemorrhagic, that is one of the main risk factors, and we'll get there. So hemorrhagic is the rest. 13% of patients will present with hemorrhagic stroke. And again, this is just a rupture of the intracranial vessels. And then blood comes out of that vessel, of course, and then causes all the pathology inside the brain. Hemorrhagic stroke has a much, much higher mortality, up to 48%. So when you bleed in your brain, it's not a good thing. Clinical presentation, it certainly depends on the vascular territory that's affected, meaning where the ischemia is in the brain or where the hemorrhage occurs in the brain. That should make sense because your brain does a bunch of different things based on what we're talking about and which lobe, et cetera. But in general, you might get a sudden onset of unilateral weakness or numbness in the extremities. You might get speech disturbances, aphasia, vision changes, certainly are common. Ability to ambulate or ataxia, vertigo, diplopia, those are all common. In some cases, you may see altered mental status, and then certainly pain or headache, more commonly with hemorrhagic stroke than ischemic stroke. So how do you spot a stroke? You should be somewhat familiar with this saying, be fast. So B is for balance, loss of balance. The patient may have loss of balance. I is for blurred or blunted vision. Face, one-sided weakness, either right or left, of course. Arms, again, extremity weakness. Could be arms or legs, but it's easier to see in the arms. Speech, so they're having problems just communicating, getting the words out. And then time for treatment, really. Time to call for ambulance should be immediate. If you recognize any of these symptoms, they should present to the ED or call an ambulance. There's a lot of signs and symptoms of stroke, and certainly they can differ between hemorrhagic versus ischemic, and then some commonalities like we see in the middle. So we talked about the commonalities for hemorrhagic. Well, the classic signs would be a severe headache, like outside of anything that you've ever experienced in your life. So the strongest headache that you've felt, and that's because of the blood going into the brain. Numbness or weakness in the face, trouble speaking. Again, we mentioned some of these. For ischemic stroke, similar. Confusion, trouble walking, severe tension-like headache, but not as severe as hemorrhagic stroke. So again, if you hear like this is the worst headache I've had, and it's very, very painful, that could be a hemorrhagic stroke. Now, we typically use a scoring system.
So, apart from headache, what critical symptom can we see that will give it up to say this is hemorrhagic and this is ischemic?
You don't know. There's going to be some other common signs and symptoms that I'm going to talk about, but you really don't know until you examine the patient and send them for an exam, a CT exam. Great question. So we should be using a scoring system. So the National Institutes of Health Stroke Scale, or the NIHSS. This score ranges from 0 to 42. The higher, the worse. So 21 to 42 is severe stroke, 16 to 20, moderate severe stroke, 5 to 15, moderate stroke, 1 to 4, minor, and 0 is no stroke. So I want you to kind of know if you see a case with a patient presenting with a 17 on this scale, that it's a moderate to severe stroke. The next slide kind of goes into how you calculate that, and you don't need to know this, okay? You just need to know this part here. And identify from a case, is this a mild stroke, is this a severe stroke, etc. So this is when we work up a patient in the ED hospital, one of the first tests that they're going to perform is a CT test. So the main reason for this is to see if there's hemorrhage. Certainly, it's going to be treated differently if you identify hemorrhage on any type of imaging, whether it's CT or MRI. So the CT test is less sensitive to detect early ischemia. So if the patient presents with stroke-like symptoms, goes to CT immediately, that CT exam may not pick up ischemia at that point in time, but at a repeat CT, maybe hours later, then you can visualize the ischemia on the CT. It's a very rapid exam or imaging. So all the hospitals can do this relatively quick. Stroke is something that when they're triaged in the ED or coming in through ambulance, all the hospitals are going to work on this patient as fast as possible. Magnetic resonance imaging or MRI, it's certainly more sensitive to detect early ischemia than the CT. And it will reveal images of ischemia minutes after a stroke. An MRI takes longer to obtain. That's why we don't send everyone for an MRI. So it could take longer. It generally takes longer to obtain. But you do get a better picture of their brain and the pathology of their brain. Another test that may be done is a carotid Doppler, and this will assess for stenosis in the carotid arteries. If there's stenosis, there may be a thrombus there, and that's why we check that. So these are two CT scans. One ischemic on the left and hemorrhagic on the right. You can see the ischemia on this CT exam by the darkened area. This is poor blood flow to that portion of the brain. And on a CT scan, it shows up dark. Whereas hemorrhagic, it would light up. So you're going to see this light, bright white picture on the CT exam. And that's how we determine whether or not they have ischemia versus hemorrhagic. Again, on CT, it can be delayed. So it may take up to 24 hours to see that ischemic insult. Other additional workup would be a CT angio. And again, this is looking for thrombus in the endovasculature system. Echocardiogram is typically done in all these patients, and this is to determine AFib. AFib is a common cause of embolus. So we're going to evaluate that. Transthoracic echocardiogram could determine valvular abnormalities, so like any type of valvular abnormality, again, is a risk factor for thrombus in the heart. And then other laboratory tests, glucose, we're going to obtain glucose, platelets because of bleeding, coagulation parameters, prothrombin, activated partial thromboplastin time, again because of bleeding, and then any other hypercoagulable labs if necessary.
The lecture being recorded on Palotso.
It is going to be. It is recorded.
Thank you.
Yeah, it should be recorded right now. So let's talk about hemorrhagic stroke. So hemorrhagic stroke is the second most common cause of stroke. It occurs in up to 27% of all strokes. Overall incidence is about 12 to 31 events per 100,000 people per year. And the mortality, like I mentioned, is extremely high. So this is unfortunate, of course. Half of the patients will generally die within the first 48 hours. It's more common in men than women. And then because of hypertension, it's more common in Chinese, Japanese, and then Black, Hispanic, and white because of the increased risk of hypertension in that population. So risk factors would be age. Look at those differences in risk factors. If you're greater than 85, you have a 9.6 increase in risk. So that's very significant. Again, hypertension is the most common etiology. It's the most important etiology for hemorrhagic stroke. It actually doubles the risk of intracranial hemorrhage. Another risk would be any type of thrombotic agents, of course. That makes sense, right? If the patient is on a blood thinner, they're at a higher risk to bleed anywhere. So warfarin will increase the risk 2 to 5 times. And then DOACs, the direct oral anticoagulants, have a higher risk than aspirin, but not as bad as warfarin. So it's 30 to 60% lower than warfarin, but they still carry a fair risk. Antiplatelets, very small risk. So like aspirin would be very small if it's monotherapy. If you start talking about dual antiplatelet therapy, then your risk goes up some. As far as the pathophysiology for hemorrhagic stroke, there is direct tissue damage, which you can imagine from that bleed. So if you have early hematoma expansion, that means that the hematoma inside the brain is expanding early on. This is certainly a worse prognostic sign. And associated with increased mortality. Other reasons or causes for increased mortality in a patient would be a low Glasgow Coma score. So if they come in with a score of 3 to 4, which is basically comatose, those patients have a higher risk of mortality. The volume of the actual blood inside the brain, and you can measure that on a CT or MRI. So if the volume is greater than 30 milliliters, that carries a higher risk of mortality. And then if the blood is in the ventricles or there's brainstem location, that certainly increases the risk. And then age, of course. So kind of know, what are risk factors for worse outcomes in hemorrhagic stroke? Now, the pathophysiology, there's several different types of hemorrhagic stroke. There could be an epidural, which you see in number 1, that's right between the brain and inside the epidural layer there. Number 2 would be a subdural, so right underneath that epidural lining. 3 would be subarachnoid hemorrhage, and then 4 would be intracerebral hemorrhage.
I have a question. If there's very big or elevated intracranial pressure, would you do surgical intervention to decrease that pressure so you can relieve that fluid?
Yes. Yeah. So any foreign or increase in volume in the brain can cause an increase in intracerebral pressure, right? Your brain is affixed because your skull, it's generally a fixed volume. So if you increase volume in that in the skull, in your brain, because of a bleed, that will increase intracerebral pressure. The problem with that is that there's nowhere for that pressure to go. So what's going to happen is it's going to push your brain down generally and cause more problems. So one of the treatments for that is to try to evacuate the hematoma, and that's what you do in a hemorrhagic stroke. So they can certainly do that depending on how severe, how much volume, etc. So as far as our concern And you don't really need to know these different types of hemorrhagic stroke. Okay, this is just for your own information. But as far as our concern, what we're going to do is focus on blood pressure management, antithrombotic discontinuation and reversal, and then management of intracranial pressure. So blood pressure goal, systolic blood pressure goal is generally 150 to 220. You don't want to bring it down too fast because that can cause some problems. And you want to lower that target to about 140 systolic within the first hour. If the systolic blood pressure is greater than 220, rapid lowering of the systolic blood pressure to less than 220, followed by a reduction to a target of 140 to 160 over several hours. So again, if they come in and present with a systolic of 150 to 220, then your target goal for blood pressure is 140. If they come in with a systolic greater than 220, you want to bring it down below the 220 and then gradually to 140 to 160. And you don't want to normalize the blood pressure because of your cerebral perfusion pressure, and we'll talk about this later on. But there's auto-regulation of the cerebral perfusion pressure. So if you bring it down too fast in hemorrhagic stroke, you can actually cause ischemia. As far as blood pressure management, we have only 3 medications. So we have nicardipine, calcium channel blocker, a beta blocker, labetalol, and clofidipine. They're all intravenous medications. Nicardipine is typically the first line agent. It's very fast acting, very titratable. Doses, it ranges from 5 to 15 milligrams per hour. So you would start at 5 milligrams, slowly titrate up to 15. Labetalol has a longer duration of effect than nicardipine, but can be used as well. Because of the longer duration of effect, you can actually bolus the labetalol IV, 20 milligram bolus followed by 20 to 80 milligram boluses every 10 minutes until you reach a maximum of 300. So you can do that, or you can start a continuous infusion. Most people would start with a bolus, and then if that doesn't work, transition to continuous infusion with labetalol. With labetalol continuous infusion, you would start at 0.5 and then titrate up to a maximum of 300, so 0.5 milligrams per minute. Clofidipine is it comes as a lipid emulsion. So if you see it, it's going to be a white substance. The lipid is there to make it stable in a solution, of course. That dose is 1 to 2 milligrams per hour starting, and then titrate to 21 milligrams per hour. So I'd be familiar with like the first line drug that you would use, be familiar with dosing of these agents, and that should be good. The biggest thing that you want to do is identify if they have any antithrombotics on board. If they do, of course, you need to stop the therapy if they haven't stopped it. And then try to reverse the effects of the antithrombotic. So again, we want to discontinue all antithrombotics and antiplatelet therapy. And then the targeted is based on the medication that they were taking. So we're going to go through all these different ones: warfarin, some of the DOACs, apixaban, rivaroxaban, endoxaban, dabigatran. We'll talk about heparin and aspirin. Your efficacy endpoint is no progression of bleed. So after you start a reversal agent, you don't want to see continued bleeding, of course. That should make sense. Safety, with all these reversal agents, you could have either thrombotic complication, so increased clot formation, which is not good, and depending on the agent, allergic reaction. But the most problematic would be the thrombotic complication. So for warfarin, you're going to give two different drugs. Vitamin K would be given, and that's usually given as a 10 milligram IV slow infusion. And then activated prothrombin complex concentrator, APCC. That can be given as two different ways, a fixed dose, which a lot of hospitals are doing because it's easier to remember that fixed dose. So you would just give 1,500 to 2,000 units as a one-time dose. Or you can dose it if you have an INR on the patient. So that, remember, the patient's taking warfarin, you check labs, and you find out their INR. Now, the problem with that is that you're going to have to get labs from the patient. There's some delay in treatment. So if you really know the patient's on warfarin, most people will go with that fixed dose. So there's not a delay in that reversal. But if you have an INR, here's the doses for you, up to a maximum of 5,000 for an INR greater than 6. For INR 4 to 6, max is up to 3,500. And then for an INR 2 to 4, maximum dose is 2,500. So what you would want to know is certainly with warfarin that we need to give vitamin K as a reversal and APCC.
Why are we giving the vitamin K at all? Why not just take out the warfarin?
Why not what?
Why are we giving the vitamin K? Why not just stop the warfarin?
You're going to stop the warfarin for sure, but the vitamin K will reverse some of those effects. So it might actually work a little bit faster than the APCC. Vitamin K is usually more readily available than the APCC. So you're going to start off with vitamin K. Once the APCC comes in to the patient's bedside, then you're going to give that. APCC is rather expensive, so it's most hospitals have it somewhat locked down, and you have to make sure that the patient is indicated for it. For apixaban or rivaroxaban, so these two DOACs, you're going to follow this dosing regimen. If the dose is 5 milligrams or less for apixaban, you're going to do the low dose reversal. If for rivaroxaban, if the dose is 10 milligrams or less, you're going to use low dose. So this one, it would be, either high dose or low dose. If this is not available, then you can use a PCC. This is a different dosing regimen than what we saw before. Most people will give Andexanet. For endoxaban or betrixaban, you're going to give Andexanet at this dose, which is a higher dose that we saw in the previous slide, 800 milligram bolus, and then 8 milligram per minute infusion for up to 2 hours. If that is not available, then you can use APCC. So for both of these, for the DOACs, you want to know like first line therapy, so it would be the Andexanet. And then dabigatran can be treated with either the MAB or activated prothrombin complex concentrate, APCC. The MAB is an anti-dabigatran monoclonal antibody, and if it's available at that hospital, it's preferred over APCC.
Some of these medications like the drugs, right? for patients that they have atrial fibrillation, and that can lead to a stroke. So that's why they're on this medication. So when we discontinue the medications again,
Because they have a life-threatening bleed. So remember, they're being worked up for a hemorrhagic stroke, right?
okay, this is specific for hemorrhagic stroke.
Yes, this is specifically for hemorrhagic stroke. So that carries a high mortality. If you have continued bleeding in your brain, you have to stop any antithrombotic, any antiplatelet, and then reverse it what you can.
So if it's not this hemorrhagic stroke, we'll not discontinue. If it's just like a transient stroke.
If it's, I'm sorry,
If it's not a hemorrhagic stroke, we're not going to discontinue.
if it's not hemorrhagic,
Yeah.
it all depends on the risk. So if they're bleeding from somewhere else, you still may reverse it. But with hemorrhagic stroke, you definitely would reverse it. And then heparin. So the reversal for heparin would be protamine sulfate. For unfractionated heparin, the dose is listed there. It will reverse factor 2A thrombin. So you give 50 milligrams once or 25 milligrams followed by another 25 milligrams if needed. Alternately, you can calculate, if you know how much heparin the patient is on, 1 milligram of protamine will equalize about 100 units of heparin. Now, this is only going to happen if the patient is in the hospital. So you know the patient is on heparin, and then they maybe bleed on heparin. Then you can do that calculation, or you can just do the more fixed dose there. Low molecular weight heparin, it reverses factor 2A, but only partial reversal of factor 10A. So you can still use it. It might not be as effective as heparin, but in hemorrhagic stroke, it's a life-threatening situation, so you would want to still use protamine here. 1 milligram of protamine will equalize about 1 milligram of enoxaparin, and then you repeat with a half a milligram of protamine per 1 milligram of enoxaparin if needed. So we had the question about intracranial pressure management. And this is just for your own information, but things to do for elevated intracranial pressure. You want to elevate the head of the bed. That should help alleviate some pressure. If the patient is in a recumbent position with the head flat on the bed, then that actually is associated with higher intracranial pressures. So elevate the head of the bed to at least 30 degrees. If they're agitated, you can give them some mild sedation. You don't want to over-sedate them, of course, because you still want to assess their mental status. But mild sedation to calm them down. If they're severely agitated, that can increase blood pressure and increase the bleed. Maintain serum sodium of a greater than 135. And then we use osmotic therapy, probably more commonly hypertonic saline. And that is going to reduce the intracranial pressure, both hypertonic saline and mannitol. Last, or in addition, would be that surgical decompression or drainage. So depending on the bleed, they would go in and try to evacuate that hematoma. All right, so we have TG is a 45-year-old male being managed for acute hemorrhagic stroke. Initial blood pressure was recorded at 226 over 183, so quite high, right? The team has been medicating TG with labetalol 10 milligrams IV push times 3 to achieve goal blood pressure. Despite the labetalol doses, blood pressure remains elevated at 199 over 105. Which of the following is an appropriate next step to manage this acute hypertension? So we can either continue administering the boluses until the blood pressure is achieved, we can start nicardipine continuous infusion at 5 milligrams an hour, and then titrate up. We can initiate enalapril at 10 milligrams orally for 1 dose, or no additional medications is needed. Blood pressure is appropriate. B, so what's our goal blood pressure in this patient? So that would be the thing, right? So he falls right here in greater than 220, so you would reduce it down to less than 220, and then gradually reduce it to 140 to 160.
Oh, the said his blood pressure was already 191.
Right.
So why would it still be in that category?
It's what his initial presentation blood pressure. So you're always going to go off of that, and that's going to dictate how fast you decrease it. Because of the auto-regulation, if you decrease it too much, that can actually cause ischemia. So in that second example where they present with greater than 220, like this patient, you're going to initially bring it down less than 220, and then gradually go down to 140 to 160 over a period of time. So right now they're at 199, which is good, but it's still not at goal.
When did they start with labetalol? When the patient came in at 226,
Right.
183, why did they not just go straight to nicardipine? Why did they go with labetalol?
That's how the case is written. So you could do either one. So you have a reduction, but 199 is still fairly high from our goal of 140 to 160. I would probably start a nicardipine drip at 5 milligrams per hour, and then titrate it to the goal of 140 to 160. Certainly, you're not going to use any oral medication, right? And we didn't even talk about enalapril, but you would never use an oral medication in this situation. Did you have a question? No.
Still a question from the problem. Since they already started out patients on labetalol, and they are getting some results, because they are coming from 226, and they've been able to bring it down to 199. Would it not be okay to continue on what is already working instead of switching?
You could. So what we would want to know is a timeline, and I didn't give you guys a timeline other than the push times 3 doses. But we want to know the timeline. So has it been hours, or has it been, less than an hour or whatever? So if it's taken a long time to get to 199, then you're probably going to go with a little bit faster acting agent. And that's the problem with labetalol, is that it's not as fast acting as nicardipine.
Sorry, bro. I thought our objective is to go slowly because we don't want to cause any complications from going very quickly.
But the reason people go to nicardipine, because it's fast acting and it's titratable. So if it's fallen too fast, then you can go down on the dose. With labetalol pushes, you can't take away the labetalol push after you give it. It's a much longer acting agent. So more people are going to nicardipine because it's easier to titrate up and down. So that would be the reason to go to nicardipine. Okay, so TG's family later shares that he recently started taking apixaban for atrial fibrillation. Due to the acute intracranial hemorrhage, what therapy do you recommend? So that would be this, right? So he's on apixaban, and it's going to be dosed based on whatever dose the patient is receiving as far as apixaban. So you're going to have to determine if they're on high dose or low dose. So you would start this therapy either 400 milligrams or 800 milligrams, and then a continuous infusion for 2 hours.
If you don't know the dose, what do you do?
I mean, you can try to get a hold of their pharmacy. If it's delayed, you're probably going to go with more of a high dose. And then The risk for this would be, and others would be thrombotic complication. But the risk of increased bleeding far outweighs any thrombotic complication as far as dose. Any other questions?
Yeah, question about discontinuing Loran's. So for ischemic stroke, are we gonna discontinue Loran's then?
Are we gonna what?
Discontinue Loran's, if it's like ischemic stroke.
Yep, we're gonna get to ischemic stroke right now. Any other questions on hemorrhagic stroke? All right, so now his ischemic stroke. So very similar to hemorrhagic stroke, there is blood pressure management, and it is quite different than hemorrhagic stroke. We're going to talk about thrombolytics. There's a slide on mechanical thrombectomy, and then talking about aspirin for acute ischemic stroke. Then we're going to spend some time on secondary prevention. And this is one of the most important things that you can do when someone recovers from an ischemic stroke. So they'll be started on some type of antiplatelet agent. They'll be started on a statin. They'll hopefully have great blood pressure management, and then looking at there any risk reduction that you can do. So ischemic strokes occur in up to 87% of all strokes, a fair amount yearly in the U.S. Almost 700,000 patients will present with an ischemic stroke. Mortality rate, luckily, is only up to 12% at 30 days post-event. So much, much lower than hemorrhagic stroke. Older adults, probably greater than 80, that mortality rate will exceed 15%. Men are slightly have a higher incidence than women. Women, as far as recovery, have a higher disability and mortality, however. As far as populations, Black, much, much greater than white, almost doubled. And it's the highest stroke-related mortality. At younger ages, Hispanic would be greater than Black population. As far as risk factors, this is important. You're going to have to know modifiable risk factors and non-modifiable risk factors. Modifiable with things that we can control, right? We can modify and hopefully do risk reduction. So that would be blood pressure, number one thing. We want to have the patient to have a normal blood pressure, hopefully. Blood pressure definitely increases, high blood pressure increases the risk of ischemic stroke. Diabetes, that should be well under control. Hyperlipidemia, that should be tackled with a statin, hopefully. Obesity, so you want these patients to lose weight. If they're smoking, stop smoking. Physical inactivity, so get them up and moving. Eating a healthy diet, and then limit alcohol and drug use, of course. Non-modifiable would be age greater than 55. Unfortunately, we can't do anything about age. We can't do anything about male gender or race, family history, or genetic predisposition. So all those can be risk factors for ischemic stroke, but you're born with what you have. So the modifiable ones, we can certainly educate the patient and help them out to decrease their risk of stroke down the road. So definitely know these modifiable and non-modifiable risk factors. As far as pathophysiology for ischemic stroke, there are three main types: thrombus and embolus, which I mentioned. So the thrombus would be something that occurs inside the brain. Embolus would be something that occurs outside the brain. And then there could be a systemic hypoperfusion. So if the patient is in shock, that could decrease perfusion to the brain. and that could cause a stroke. That's more of a heart problem, like we talked about yesterday with decompensated heart failure. So with ischemic stroke, there's a phenomenon called a penumbra. So you initially have necrosis here, and then a penumbra is formed. And what you want to do as a clinician, as you treat this patient, is to limit this expansion of the penumbra. The penumbra is salvageable tissue that surrounds the infarct. So you want to limit this as much as possible because that's brain that you can actually save. And limiting that would be blood pressure regulation and all the things that we're going to talk about. So as far as timeline, this is kind of what should happen in the ideal situation. If you have a patient with stroke, they should get early EMS, early arrival to the ED, emergency department. Within 25 minutes of presentation, they should get a CT, and that's going to assess for hemorrhage. If they don't have hemorrhage, we're going to treat them as such. Then you'll assess blood pressure, administer blood pressure medications if indicated, evaluate for thrombolytic therapy, which we're going to talk a lot about. So if they're eligible for thrombolytic therapy and have no contraindications, you want to give that within an hour of presentation. The sooner you give it to them, the better the results down the road are for the patient. If they're eligible for mechanical thrombectomy, you can go that route if the hospital does it. Not all hospitals will do a medical thrombectomy, but you can certainly entertain that. As pharmacists, we're not going to be doing that. That's going to be more the neurologic surgeons. And then initiate aspirin within 48 hours of symptom onset. So our goals for ischemic stroke, certainly to restore that cerebral blood flow. Remember, you have ischemia in your brain. That's not a good thing. So you want to restore that blood flow to your whole brain, but certainly to that ischemic part of it. So we're going to look at blood pressure. Again, thrombolysis will restore blood flow, and then maybe a mechanical thrombectomy if they go there. We want to preserve that ischemic penumbra. And we're going to do that with rapid reperfusion and then prevent complications. That's why you're looking at glucose, blood pressure, and temperature. All those things can cause complications in patients with ischemic stroke. Once that is done, then you have a stable patient. Then you're going to monitor the patient for any other complications or any other CNS deficits or deterioration. Do you guys want to take a break now, or let's take a break now? We'll take a 10-minute break, come back at about 3:30.
Yeah.
Oh, it is. It is late. I see why that is. Because of it. So I can
Me da risa. ¿Dónde está? Heidi está aquí ahora.
Dr. Bowling said people in my program
Espérate que yo tengo.
and he said,
Ya no va a dar tiempo de estudiar de descanso.
that's gonna be funny.
Pero yo no tengo antes, a la casa. Ajá, de pipí. ¿Verdad?
My ex-girlfriend is in Switzerland. He's a farm ex-girlfriend.
Oh, I thought.
No, not that. She's a pharmacist. And I'm here. She's my kind of friend. Deborah doesn't like that.
But as soon as you said girlfriend, I was like, everyone's right
No, she's my friend still. Yeah, about yourself, how you doing?
I cannot complain.
Oh my god, I think everyone is. Like this semester, I don't know what's happening. Yeah, me too.
Even before that, it's the I feel like because I know we're like exams. We have 2 exams. Quiz exam. Or for you guys, exam. And there was
A quiz, and then exam, exam, quiz, and chase.
Yeah.
Yeah, but it was basically like an exam. It was, we had to like 6 lectures. Yeah.
And it's just.
Yeah, me too. Like I didn't have any time to study.
And honestly, it's just yeah. I tried to support.
Yeah, I need to study like today.
Is it like extensive?
No, not that bad.
It's only just chronic. So let me speak to me real quick. One day is
Next week is gonna be a little more.
yeah, because like the next exam. Yeah.
At what hour do we finish the Dr. exam? 4:30? Oh my god, right.
I think so. It's really lecture.
Una función.
Yeah,
¿Por
right.
qué podemos hablar con el doctor Naim a ver si podemos mover el quiz?
Friday.
Actually, no soy vicepresidente, ¿no?
Pero ¿qué tú piensas? ¿Eso podría ser una
Pueden ser corredores en camiseta, pero
Yo pienso que ya están.
Estamos tarde.
Primero porque ya vamos a comer el baño. Y ella no va a buscar mucho.
It's objection.
No,
I was
eh,
like, oh, yes. But if it's for basketball, I don't think I'll live to say that it's for
And now it's
like,
pero no creo que sea por. Espérate, el examen del lunes.
No, estoy hablando de mantener del caso.
Uy.
Del caso
oh wait, no, you're right.
Estamos tarde.
¿Verdad? Porque yo me
Pero
quiero ver
yo
más
pienso
tiempo
que
que estoy aquí. Deberíamos verlo bien y que no tenemos nada.
Podemos enviarle un
Oh,
email.
I do. We have some.
tiene que ser alguien que ya la haga caso.
Tiene que hablar.
Y la persona que no va a poder estar aquí es
For the
Charlie,
last exam, what do we like?
do you think
For cardio, we have room one.
Dr. Naim can
Watch the quiz and the case for Friday.
I think we
I
can.
doubt it.
Yeah,
But we can
Did it?
try.
Didn't Jessica
We
already,
tried to her because
Did
it's
Jessica
too
ask
much.
for
We
that?
have
Jessica already asked her to move something involving Care Lab and PT, and she said no, and that we should have looked at the schedule sooner.
yeah, it's gonna have to like.
Oh, that was her
That was
remediation.
Kayla.
But I feel like it's gonna be the same answer for the top 200 exam and the case quiz.
Oh wait, so you guys want to do the case application Friday?
Porque te sientas otra vez.
Why?
I'm so ready to get it done. Can't just have it done. I mean, you can remediate.
No, there's no
Last time Friday,
There's no radiation.
I'm going to that for you. Like for others. If we ever. I think we might.
So llegamos a. Pero
Ya.
no te gusta el no, lo que está complicado es tú. ¿Sabes? Porque tienes que llegar a tu como si yo nunca hubiera ido.
Ayuda. Ayuda, mami. We got this, guys. Two more weeks until
De verdad que yo no sé. Ya me di por vencido, en verdad. Estoy cansada, I'm tired. I need to rest.
Mhm. Yes. Yeah. Oh, so.
Why did we increase the risk of the interest? I know. So the answer was increase this. So.
Discontinue.
Yeah, it's like the Miranda is going to That's crazy.
All right, let's get back to ischemic stroke. So blood pressure management for ischemic stroke is drastically different than hemorrhagic stroke because blood pressure lowering within that first seven days of acute ischemia can result in decreased cerebral blood flow and actually worsen symptoms. So you certainly want to optimize your cerebral blood flow. According to the guidelines, patients with elevated blood pressure generally should remain untreated unless it's high, like greater than 220 over 120 for blood pressure. So 220 systolic over 120 for diastolic. If there's evidence of aortic dissection, acute myocardial infarction, pulmonary edema, hypertensive encephalopathy. So in those situations, you do want to lower blood pressure. or there's intention to administer a thrombolytic like alteplase or tenecteplase. So if none of these are above, your general goal blood pressure for this patient would be less than 220 systolic and less than 120 diastolic. Okay, so you're not going to rapidly decrease your blood pressure in these patients if the patient doesn't have these three things. You want to correct any type of hypotension and hypovolemia. Hypotension would be bad, again, because of decreased perfusion to the brain. So you want to resuscitate that patient if they come in hypotensive. If they have, if you're being worked up for thrombolytic therapy, your goal blood pressure right before you give the thrombolytic therapy would be a systolic blood pressure of less than 185 and a diastolic pressure of less than 110. And then permissive hypertension if thrombolytics are not being administered. So you're going to do this because of the cerebral perfusion pressure and the autoregulation. So you have cerebral blood flow on the y-axis, cerebral perfusion pressure on the x-axis. You can see in a normal patient, your cerebral perfusion pressure is maintained over a pretty wide range. Cerebral blood flow is maintained over a pretty wide range of cerebral perfusion pressure until you get on both ends, so elevated or very low. In chronic hypertension, this curve is shifted to the right, so it's still maintained, but maintained at a much higher point. And that's why you don't want to dramatically reduce it in someone who has ischemic stroke, who has a history of chronic hypertension, in that you can decrease their blood flow to the brain even more. In ischemia, you kind of lose this autoregulation and have a further decrease in cerebral blood flow. So again, it's most important for ischemic stroke, where you want to use permissive hypertension unless they're being treated for one of those three things like I mentioned. What was your question?
Previous slide. So if the patient comes in and is probably having a blood pressure of 200, 140.
200 to 140.
Yes.
Yep.
What would be the indication? Because in that case, can we say 21?
If they come in 200 to 140 and they don't have one of these three things, your goal is less than 220 to less than 120.
Let us 220, 120, that's the guideline there. But this patient is coming in here with 200 over 140 and is having a stroke. Should I still initiate a treatment?
So the diastolic blood pressure is still not a goal. Your diastolic blood pressure would be less than 120. So you're still going to treat that patient's blood pressure. So it's either one, the systolic or the diastolic.
Okay.
Okay? Does that make sense? Either one of those. So if the patient came in with, 240 over 110, and they don't have this, you're going to still bring them down to less than 220. The systolic. Okay?
Okay.
But, so you should know this. Certainly, right? And this is permissive hypertension. And then know these three categories. Because if your patient is in one of these three categories, you're going to treat them differently, especially with the thrombolytic. So if they are eligible for thrombolytic and the blood pressure is greater than 185 over 110 diastolic, then you're going to treat the patient with either labetalol, nicardipine, or clobidipine. So the same drugs that we talked about with hemorrhagic stroke, a little bit different with the labetalol dose. The other ones are the same. So before you give a thrombolytic, the blood pressure has to be less than 180 over 110. And that's because of risk of bleed. So thrombolytics will certainly increase the risk of bleed. If you have a patient who's hypertensive before you give the thrombolytic, that increases the risk. So you want to reach that goal before you give it and during the whole infusion of the thrombolytic therapy. And then after the thrombolytic therapy is done, administered, you want to maintain a blood pressure of less than 180 to 105 for at least 24 hours after the thrombolytic. Okay?
If this patient came in already using a thrombolytic, and then this patient has come into the hospital, is already using maybe a DOAC, or is also using aspirin.
Right.
And his blood pressure is something like we said 240 over 120 or whatever. Are we still going to look for, are we going to stop that thrombolytic agent or the antiplatelet and wait until it gets to 180 to continue, or we'll just allow it to continue?
So thrombolytics are different than DOACs, right?
Yes.
And different than antiplatelets. You're never going to have a patient who's receiving thrombolytic outside of the hospital. So those are administered in the hospital. If they come in on warfarin, DOAC, or antiplatelet therapy with ischemic stroke, your blood pressure is the same as if they came in without any of those drugs.
So we still continue those medications?
There are some contraindications to thrombolytics, which we'll get to. In, I think, a couple, like 2 slides, we're going to talk about, 2 or 3 slides, we're going to talk about contraindications. So thrombolytics, the benefit is to reduce disability of the patient due to stroke. So from the studies, it certainly, they certainly do that. However, there's no effect on mortality, okay? So it's just for improvement in disability scales and endpoints. It is the first line therapy in patients with acute ischemic stroke. So if the patient is coming in with acute ischemic stroke, they should be worked up to see if they're eligible for a thrombolytic. The patient has to meet all of these inclusion criteria. So age greater than 18 years of age, diagnosis of ischemic stroke with a neurologic deficit, so it can't be a mild stroke. Symptom onset has to be less than 4.5 hours before treatment. Okay, that's an important cutoff. So if they come in with symptom onset of 5 hours, they're not eligible for thrombolytic. So that 4.5 hours is a pretty good endpoint marker to remember. There's many, many contraindications, and we'll get to there in a minute. The biggest side effect for thrombolytic therapy is bleeding. And a lot of the contraindications are related to that. There's, in fact, a 10 times increase in the risk of intracranial hemorrhage after thrombolytic therapy versus placebo. So it goes from 0.6% all the way up to 6.4% with thrombolytic therapy. So the bleeding risk is there, and we have to be aware of it and exclude the patients who are at an increased risk of bleeding. So for eligibility, remember the timing of symptoms, that 4.5 cutoff, that's important. Less than that, the patient has to consent to this, or their caregiver, because of the risk of bleeding. Evaluate contraindications, look at the patient's blood pressure and make sure it's within goal before and during thrombolytic therapy. Evaluate their glucose and coagulation studies. So this is where the main indication is less than 4.5 hours. We can give alteplase or tenecteplase. And again, it should be given as soon as possible. So if they present to the hospital and you go through the criteria, you should administer this within the hour. If the patient has symptoms that are from 4.5 to 9 hours from onset, so let's say they went to bed with some symptoms, they didn't think it was bad, they woke up with persistent symptoms and stroke situation, then they go to the hospital. You need to do an MRI to rule out any type of bleeding. That is recommended, and the benefit is really unknown in this situation. So a lot of places are not going to be given thrombolytics in this situation, but if they present, certainly before that 4.5 hours, most will give it if they're eligible. This is a nasty slide that goes over the algorithm and decision tree. What you guys want to look at is mainly this left-hand side with the 0 to 4.5 hours, okay? Don't really worry so much about this part here. It gets too nuanced as far as we're concerned right now. So I would just focus on this left-hand side. So as far as dosing of thrombolytic therapy, again, our two agents that we're going to use is Alteplase and Tenecteplase. Tenecteplase, based on the studies, is actually increasing in usage, and it's shown to be pretty effective. The reason why it's increasing is because it's a little bit more simple to administer. So starting with the Alteplase, the dose is 0.9 milligrams per kilogram with a maximum of 90 milligrams. You give 10% of that calculated dose over 1 minute as a bolus. The other 90% would be infused over an hour. So if you have a 60 kilo patient, the total dose, 0.9 milligrams times 60 is 54 milligrams. 10% of that, 54, is 5.4 milligrams over a minute. The remainder, 48.6 milligrams, is administered over an hour. So it's a little bit complicated to do, but you certainly need to know these calculations as far as total dose, bolus, and infusion. Tenecteplase is 0.25 milligrams per kilogram with a maximum dose of 25. And we have breakpoints in the dosage. So if they come in 60 to 70 kilos, you're just going to give 17.5 milligrams. If they come in 80 to 90 kilos, you're going to give 22.5. So it's much easier. You don't have to do any really calculation. You just look at the table, and that's the dose. And then it's bolused over 5 seconds. So there's no continuous infusion with Tenecteplase. And that's one of the reasons why a lot of centers are going to Tenecteplase, because it's easier to calculate the dose and easier to administer. So you should be able to get an accurate dose relatively quick. And the studies back it up as well. So the contraindications, you need to know this for sure for thrombolytic therapy. So you want to look at the absolute contraindications. This would be anything that would put the risk, increase the risk of bleeding. So any recent or history of intracranial hemorrhage, you don't want to give thrombolytic therapy. If the patient has structural cerebral vascular lesion, intracranial neoplasm, so any oncology in the brain, ischemic stroke within 3 months. So if they came and this is their second or third stroke, and their last one was within 3 months, you don't want to give it. Possible aortic dissection, that's not a good thing. Any active bleed, you're not going to give it. If the patient is bleeding, you're not going to give thrombolytic therapy. Significant head injury or facial trauma within the last 3 months. And then finally, recent intracranial or spinal surgery. So all of these things would put a patient at an increased risk of bleeding. And remember, that's one of the biggest safety endpoints that we have with thrombolytics. So I think these ones are relatively easy. The relative contraindications are a little bit less clear. So history of chronic or severe or poorly controlled hypertension. If you have severe uncontrolled hypertension at presentation, greater than 185 or diastolic of 110, again, we said that if you bring it down to within goal, then you can give it. So that's relative contraindication there. Prolonged cardiopulmonary arrest when they're doing chest compressions for greater than 10 minutes. That's a rather long period of time to do chest compressions. But the risk there would be bleeding in your thoracic cavity. Major surgery within 3 weeks. History of ischemic stroke greater than 3 months prior. So this was within 3 months over here. But if they have any history of ischemic stroke, then you might not want to give it. Dementia, recent internal bleeding within 2 to 4 weeks. Non-compressible vascular punctures. So if the patient has a vascular puncture and you can't compress it to stop the bleeding, then you may not give a thrombolytic. Pregnancy, active peptic ulcer because of GI bleed. If the INR is elevated, so let's say they're on Coumadin and their INR is 2, what we would probably do is reverse that INR and consider giving thrombolytic therapy. Pericarditis, anything that, to do with the pericardial sac, that would increase the risk of bleeding there. Age greater than 75, those patients you're generally not going to give it. And then diabetic retinopathy because of increased reading and bleeding in the eye.
What is the difference between those two?
What's the difference
What is the
between?
difference between those two, the absolute and the relative?
So the absolute ones, you're definitely not going to give it. These ones, there's a gray zone where you may give it. Blood pressure would be the great example, right? If it's greater than 185, you're not going to give it until the patient is at goal. Then you can give it. But the ones with like history of ischemic stroke greater than 3 months, it's really a judgment call. So they're going to have to weigh risk versus benefits. You're going to talk to the patient and their caregiver and determine risk versus benefit, basically. But the absolute, certainly know those. Post-thrombotic monitoring. So let's say they give alteplase in the patient. Remember, you're going to continue to monitor blood pressure, keep the blood pressure less than 180 over 105. And you're going to monitor this rather frequently, as shown here. The blood glucose, aim for 140 over 180. And this is to prevent worse outcomes, neurologic outcomes. You don't want hypoglycemia, that can be detrimental. And then angioedema. These drugs are associated with angioedema, so monitor for angioedema after administration and treat if the patient has it. And certainly a neurologic exam, that's going to be one of the most important things to monitor. Ongoing and repeated neurologic exams. You may send the patient to get a repeat PET CT. You want to evaluate any new hemorrhages, of course, in the brain or elsewhere. And if those occur, you can give drugs, which you don't need to know, to try to reverse or stop that bleed. All right, so let's practice a calculation. So what if the patient weighs 110 kilos? What's the total dose of alteplase we would give?
9 times 10 is 0.9. 99.
Okay, so the patient's 110. So it's 0.9 milligrams per kilogram, but a maximum dose of 90 milligrams, okay? So you're not going to give 99. You'll stop at 90. Okay?
Prof, do we need to memorize this? So
Yes. I think this would be important. It'll come back. So if I give you a case and I say the team wants to give alteplase, you're going to have to calculate a dose. If I say the team wants to give tenecteplase, you'll have to determine a dose. So the total dose in that case for 110 kilo patient would be 90 milligrams, right? So your total dose would be 90 milligrams. What's 10% of 9? 9 milligrams over 1 minute. So it's going to be a bolus dose over a minute. And then the remainder of that, so 90 minus 9 is what? 81 milligrams over an hour. Okay? So go through a couple examples on your own. Just pick a weight and go through a couple examples. I almost guarantee you're going to see this again. The example 2, we already did on the previous slide. So if the patient is 60, what's 60 times 0.9? 54. So that's the total dose. 10% of that is what? 5.4 milligrams administered how fast? 1 minute. Great. And then the remainder over how much period of time? 1 hour. Great. Okay? So please practice that. Mechanical thrombectomy. This is just for your own information. The patient can be a candidate for this. This is a surgical procedure. That's why it's only FYI. If the patient presents within 24 hours and they have a large vessel thrombus, and the center or the hospital can do mechanical thrombectomy, this could be an option, and it may be better than thrombolytics. So if it's done early within 6 hours, it's certainly superior to thrombolytic therapy. It can even be done with thrombolytic therapy. And if they present 6 to 24 hours, they may consider it. So it's a procedure that goes up, and they go in usually the femoral vein all the way up and try to extract the embolus. So all patients should get early aspirin therapy. This early aspirin therapy reduces long-term mortality and disability, so this is extremely important. As far as safety, you guys probably learned this, GI irritation and an increased risk of bleeding, right? I would say it's very small. The dose is going to be 160 to 325 milligrams, and it's recommended to be administered within 24 to 48 hours of onset. However, it's generally delayed for 24 hours if thrombolytics have been given. So you want to start this 24 hours after the completion of the thrombolytic therapy. And if you give it earlier than that, that may increase the risk of bleeding. So every patient with acute ischemic stroke should be on aspirin within 24 to 48 hours of symptoms.
If that patient goes on 81 milligrams, that is redouble.
81 milligrams?
Aspirin.
Yeah, so if they were receiving it before their stroke?
Yes.
So you're still going to go up to 160 to 325. So you would cancel that, and now the new dose would be 160 to 325. So you could consider short-term dual antiplatelet therapy. This is more for minor stroke, so a NIHSS score of less than 4. So if your patient has moderate to severe stroke, you're not going to consider this. So if they come in with minor stroke with a score of less than 4 and no cardioembolic source, so this is all intracranial generally, the patient could consider this. You should not give it in patients who receive thrombolytics. So if they receive thrombolytics, they're already out of this pathway. And this should be similar to aspirin, administered within 24 hours of symptom onset. So you're going to give aspirin, 160 to 325 load, and then 50 to 100 milligrams daily. So it would be similar to the 81 milligrams, plus clopidogrel, 300 to 600 milligram load, and then 75 milligrams daily. Duration of the dual antiplatelet therapy is 21 to 90 days. And then you would consider continue aspirin after that. Any questions about ischemic stroke? So the importance are blood pressure management, evaluate the thrombolytic therapy, and to give aspirin. Okay? That's what we're going to do acutely. Now, TIAs, or transient ischemic attack, again, the difference between ischemic stroke is that there's a neurologic dysfunction in ischemic stroke, and it lasts for at least 24 hours, so greater than 24 hours. For TIA, the episode of neurologic dysfunction only lasts a short period of time, less than 24 hours, and there's no evidence of acute infarction. Okay? That's the main difference. As far as initial workup, it's exactly the same. You're going to CT the patient, evaluate if they have a bleed up there or any findings, ischemic findings. You're going to look at blood pressure management, EKG twice. You only have to do it once. Evaluate the carotids. These patients have a higher risk of developing a stroke in the next 3 months, which probably should make sense to you, because if they have a transient ischemic event, so they have ischemia, it hasn't resulted in a major morbidity yet, their risk for stroke down the road increases. Preventative therapies for TIA would be aspirin, statin, and blood pressure regulation. So after they recovered from the ischemic stroke, then we're talking about secondary prevention to prevent another stroke down the road. For this, if they have a cardioembolic source of that stroke, you're going to start on oral anticoagulant therapy. If there's a non-cardiac embolic stroke, so the stroke was just in the source of the stroke was in the intracranial, then antiplatelet therapy. So that's your two pathways. So you have to evaluate cardioembolic. If there's a clot that moved from like the heart to the brain, then it's oral anticoagulation. If it was originated in the brain, then it's antiplatelet. You're going to do intensive statin therapy, certainly with atherosclerotic disease, and then blood pressure management for all patients. Now, the recurrence of stroke.
I have a question. So cardioembolic, is that originated like from the heart and went to the brain?
Yes.
And non-cardioembolic, is that originated in the brain?
In the brain, correct.
Okay.
Yes. So the recurrence of stroke is very high. We already said there's a high recurrence of TIA. The annual risk of recurrence in both TIA and stroke is 3 to 4%, even with antiplatelet therapy and other therapies. The overall risk depends on the age. So the older you are, just like the risk factors for ischemic stroke, the older you are, the higher your recurrent risk is. And then dependent on comorbidities, et cetera. Secondary preventative therapies for TIA and stroke are the same. So it's easy for secondary preventative therapy. So again, oral anticoagulation therapy. This is treatment of choice for stroke with atrial fib or atrial flutter. Again, it comes from the heart. The patient is in atrial flutter or fib, and there's an embolus in the heart that develops from the abnormal rhythm. That goes to the brain. If that happens, they're going to be on typically warfarin, dose to an INR of 2.4 or 2 to 3. Or a direct oral anticoagulant, a DOAC. Antiplatelet therapy, this would be, this reduces the risk of stroke, MI, or death by 22%. So if you have intracranial pathology or source, and you start antiplatelet therapy, that should reduce further stroke, MI, or death by 22%, a great reduction. This is a cornerstone in secondary prevention of non-cardioembolic ischemic strokes. First line options are aspirin, clopidogrel, dipyridamol, extended release, and combined with aspirin. Most are going to go with aspirin therapy. However, the choice of therapy is based on cost, bleeding risk, and convenience to the patient. Aspirin is most studied in this, and that's why majority of patients will go towards this, and providers will use aspirin over the others. It's recommended to be initiated 24 to 48 hours following symptom onset, like we mentioned. Efficacy, significant reductions in 14-day recurrence of stroke. So there's a 14% relative risk reduction in mortality at 4 weeks. We mentioned the safety. Remember that some people can be allergic to aspirin, so you want to be careful with that. Clopidogrel is an alternative to aspirin, especially if they have an allergy. So if you come and see a case where the patient is allergic to aspirin, you're not going to administer aspirin. Clopidogrel would be a great option for that patient. It's slightly more effective than aspirin in reducing MI, stroke, and cardiovascular death, with a similar bleeding risk than aspirin. Administration is 75 milligrams daily. And it may be less effective in patients with cytochrome P452C19 variants because of metabolism. The last one, dipyridamol, extended release, and aspirin combination is also an acceptable initial therapy. However, it's not that common. It's slightly more effective than aspirin at prevention of recurrent strokes and has a similar efficacy than clopidogrel, but it has more GI bleeding and headache with this combination product. You're going to do dipyridamol ER 200 milligrams and 25 milligrams of aspirin twice a day. And it needs to be that ER formulation and not immediate release. Because of the BID dosing, this cost increase over just aspirin and significant side effects, this is generally less desirable, and it's reserved generally for patients who cannot tolerate aspirin or clopidogrel. Statin therapy, so all these patients should be on high intensity statin therapy. So if they've been diagnosed with ischemic stroke or transient ischemic attack, regardless of their baseline cholesterol. So it doesn't matter what their baseline cholesterol is. If they have ischemic stroke or TIA, they should be on statins. Remember, with statins, there is an increase in myopathy. So you want to monitor myopathy. You also want to monitor LFTs or liver enzymes. There's a small risk of hemorrhagic stroke, but extremely small. Generally, avoid statin therapy if you have a history of intracranial hemorrhage. Dosing for atorvastatin would be 80 milligrams, and that's the most studied drug. You could use any of the statins at high dose, though. For secondary prevention, one of the most important things you can do is a regulation of blood pressure, or maintaining a more normal blood pressure for these patients. So that would be something to remember. That will certainly reduce the stroke reoccurrence, and you want to just maintain them within goal. Other risk factors for reduction would be diabetes, so make sure that's controlled or well controlled. Obesity, these are modifiable risk factors. Physical inactivity, make sure the patient is moving. Sodium restriction, less than 2 grams per day. If they're smoking, they should stop smoking. That certainly increases the risk of ischemic stroke. And then moderate alcohol use. So as pharmacists, what role can we play when managing these patients? There's a lot. In emergency response, certainly we have a role there. There's pharmacists who provide services in the emergency department 24/7. So we can assist with thrombolytic eligibility. So we can interview the patient, go through all those screening indications, contraindications, et cetera. We certainly can help with blood pressure control, picking the right blood pressure medicine and making sure that the patient is within our goal. We can help pick out reversal agents and remind the practitioners which reversal agent to pick based on whatever therapy they may have been on before their bleed. Adjust doses for organ dysfunction. Certainly manage complications like seizures, cerebral edema, et cetera, and just overall monitoring for these patients. Multidisciplinary team or interdisciplinary team involvement is very important. We participate in code stroke response teams in hospitals, certainly provide recommendations and education to the team. Post-acute care, pharmacists can play a huge role, right? We talked about all those secondary preventative therapies, and as pharmacists, we can help make sure the patient is checked off on all those things that we just talked about. And then certainly, last but not least, patient education, adherence to those preventative therapies, lifestyle modifications, and then just general education on stroke warning signs. Summary, TIA is a transient neurologic episode caused by CNS ischemia without acute infarction, while stroke is a CNS infarction accompanied by overt symptoms and neuroimaging suggestive of permanent injury. Ischemic strokes are caused by atherosclerosis or emboli, while hemorrhagic strokes are typically caused by trauma or blood vessel rupture. Blood pressure goals are different between hemorrhagic stroke and ischemic stroke, so make sure you're clear on the blood pressure goals. You're going to need to know that for sure. Thrombolytic therapy is limited to administration within 4.5 hours of symptom onset, generally. There are some cases where you might use it elsewhere, but for the purposes of us, we're going to limit or just focus on that 0 to 4.5 hour time period. Secondary prevention is very important, as we just talked about. Antiplatelet therapy, statin therapy, blood pressure management are keys in that secondary prevention. Hemorrhagic stroke is primarily managed by blood pressure regulation, whereas ischemic stroke, you're generally going to use permissive hypertension. So hemorrhagic, remember, high blood pressure will increase bleeding, and you want to correct that fairly soon. So those are the differences between hemorrhagic and ischemic. Any other questions? Excellent. Thank you, guys. Have a great day.
Thank you so much.